the agenda. So let me share my screen. Get the PowerPoint up. Is everyone seeing that?
Yep, sure am.
Okay. And here we go. Ta-da. So hi, everyone. I'm Jeff Taylor. I'm a longtime member of the CAB. I actually helped start it 30 some years ago and have a long history in HIV research. I'm currently director at the HIV and Aging Research Project in Palm Springs. But I kind of started my research journey back in the 80s when I found out I was positive. There were no treatments for people who weren't symptomatic at the time. You had to have KS or PCP to get access to AZT. So I enrolled in one of the early ACTG AZT trials for asymptomatic folks. And this is back in the days when you were getting up every 4 hours to take a really high dose of pills that made you really sick. I was lucky that I got a placebo and, did well on the subsequent trial or subsequent version of that trial. And, there were no other drugs available really. So I just kept signing up for trials, volunteering to be a guinea pig, kind of in a desperate bid to get access to treatment and keep myself alive. So that's what I did until the cocktail came out. And I started in Chicago. That's where I was diagnosed, and joined the ACTG trials at the Northwestern site there. And then, after another year of that, I realized that one more Chicago winter would kill me, and decided to move to sunny San Diego, in large part because, they were and still are one of the leading, virology research centers. And Doug Richmond was and is a superstar. So that kind of made up my mind for me, in addition to all the other wonderful attributes of San Diego. So that's kind of how I got to doing the work that I do. And now that I live in Palm Springs, which, if you're at all familiar with it, is kind of God's waiting room for older people living with HIV. A lot of people from around the country, but especially California, who are positive end up moving here, mainly for economic reasons. They get priced out of the more expensive coastal cities. Started in the 90s with the dot-com boom in San Francisco, when people who were fortunate cashed out and moved here, because not only was it, pretty and nice weather and a calmer pace of life, but they had pretty good services with Desert AIDS Project, and that's continued. So, people move out of state, they lose a lot of the good benefits that California has. It's one of many symptoms of the kind of financial aspects of living with HIV. So that's a little bit about me, and I will keep going. So as we know, people with HIV are getting older. Back in 2018, they said it was, reached 50%. That's now closer to 70. I haven't seen any new data. The CDC is kind of overwhelmed with COVID and monkeypox to be to crunching those numbers. But I always enjoy this slide. It's a good visual depiction of kind of what our healthcare and social service system is doing, kind of lying there blithely ignoring the problem that's about to crash on top of them. And, it's here now, and we need to be doing something about it. So these are some older data showing the increase of people living with HIV who are over 50. And of course, that's only going to be going up because, fortunately, the good news is people aren't dying as they once were. They're living into old age. We have people here in their 90s, and there's a famous Lisbon patient who lived to be 100. So aging is upon us, and here we are. So what does aging look like in people living with HIV? So the charter cohort that we're often familiar with, because UCSD has been a leader in that as well for 30 some years, is kind of showed the breakdown. And, about half of people, fortunately, are doing well neurocognitively, but there's a good third who have asymptomatic neurocognitive impairment. So it doesn't show up in their daily lives. They're not really aware of it, but it's there and concerning, because the question is, is that going to stay stable, or do people progress into the mild neurocognitive or HIV-associated dementia pie slices there on the chart. So, that's something that people are concerned about in the HIV community, both the providers and, the better educated patients who are aware of this are also really concerned as to what's going to happen to them. And they see people in their community losing their cognitive function, early in their 50s and 60s, not, 70s and 80s as you would see in the general population. So one of the hallmarks of aging with HIV, of course, is that it's accelerated and or accentuated aging in people with HIV. And that's why when we talk about aging in people with HIV, we start at 50 instead of 60 or 65 as you would in the general population, because that's what the data have shown. And concerningly, inequities show up in aging as well. African Americans and Latinos have 3 to 4 times higher rates of chronic health conditions in people who are, and this is Medicare data. And the same is true as women as well. They have higher rates as well. So there's a lot of social inequities to be looking out for. And these are often the underserved people who don't get the best health care. So it's doubly concerning because not only do they have higher rates, but they may not be diagnosed or addressed as well as they should be. So it's definitely something that needs to change. So of course, one of the hallmarks of aging is frailty. And that's, just the inability. We see it in our older parents or grandparents, slowing down, not being able to move around as quickly. And this shows that the prevalence of frailty, move around my Zoom stuff so I can see my own slides. The prevalence is much higher in people living with HIV. So life expectancy. So the good news is that the life expectancy, as you can see in the top 2 lines, comparing positive versus negative, has been trending upwards, and it's now very close to normal with 2016 data, and it's getting even closer, but it's never going to meet. And what we need to be looking at are the lines below, which I think are more important for both people who care for and people living with HIV. And that's who's comorbid free. So not having the aging comorbidities that we're concerned about. And as you can see, the rates are higher for people living with HIV, and they're not changing much. So that's of concern. Because, with length of life, you want to think about quality of life. So not just lifespan, but health span. And this is another kind of article from JAMA showing the comorbidity-free life expectancy of people living with and without HIV. And so again, it's kind of the same numbers, right? Showing that life expectancy is closing the gap, but comorbidities are not. So that's really where our focus needs to be when it comes to addressing clinical care. So, we're a research group at UCSD. We're part of the ACTG. And apologies to Dr. Benson, because this is the presentation I gave at the summer meeting 3 months ago now. But we have a very active CAB presence within the ACTG, thanks to the activism in the early days. And the DAIDS has been very good about ensuring that there's a strong community voice and that they're integrated into the research agenda. And so periodically the community group, so the GCAB now, the global CAB, puts together its research priorities. And you can see that aging is right under a cure. People are really concerned about this. And globally, as people get start living longer, people are getting access to treatment. It's happening everywhere. And again, in research limited settings, people may not be getting the kind of comprehensive clinical care where aging comorbidities get diagnosed and addressed. So recently, the ACTG formed an HIV and aging working group. And so what are the challenges and solutions that we're facing in context of research, and especially within the ACTG? Well, the biggest problem has been getting intervention studies approved and funded. It's a huge unmet need. Obviously, we've spent years kind of characterizing it and highlighting the problems, but what have we done to address those problems to actually improve the quality of life of people living with HIV? And the answer, sadly, is not as much as we should. So within the ACTG, there's a lot of priorities. It's a huge group. They cover, a huge breadth of research priorities, such as cure, other co-infections, recently COVID, and now monkeypox with the STOMP study. So they're, to their credit, they're being nimble and addressing things as they emerge, but this is kind of a long simmering problem that is really not getting the attention that we feel it deserves. And, one of the questions is, now that the people living with HIV are, the majority of them are over 50 and technically aging, should that influence the funding priorities? So should there be kind of a democratic principle there in terms of the majority getting, if not the majority, at least greater access to the research resources? And then other questions that, still kind of bedevil the whole research funding issue is outside funding, inter-institute collaborations within the ACTG. DAIDS, of course, controls those budgets, but, aging encompasses a lot of different comorbidities that are spread across the various NIH institutes. NHLBI is a good example of one that has stepped forward to take on the combined MAX and WISE studies so that they wouldn't get defunded, as was being threatened a number of years ago. And just getting the various parts of the NIH to cooperate. It's a bureaucracy. We've all had our challenges with that. And just within DAIDS, you've got, the Office of AIDS Research that's supposed to be coordinating across the institutes, NIAID, et cetera. So it's, kind of a multi-headed beast that we're contending with and trying to get everybody working in the same direction. It's been a challenge that we haven't quite solved yet. And then, we also need to be partnering with socio-behavioral research, because the issues of aging are not just clinical, but they're psychosocial. And so that's where the socio-behavioral research group that was newly funded within the ACTG comes into play. And we're looking to kind of bring them into that. I mean, ideally, they would be working across all the research areas within the ACTG, because it's clinical research and involves people, and is therefore by definition socio-behavioral research as well as clinical research. And we need to have that perspective across the board, especially in cure research, where we're doing a lot of those early studies that involve a lot of risk and no benefit, and certainly within the aging arena as well. So what are some of the gaps that we see in aging research? And one of the big ones is the focus on people who are truly old. As I mentioned, we start defining people as older in HIV at 50 because we see these comorbidities emerging sooner. But you look at the cohorts, the people who enrolled in the studies, and we have very few who are over 65, and even fewer who are in their 70s and 80s and 90s. And that's where we start seeing these comorbidities in large numbers. Most of our cohorts, and this is kind of an artifact of the history of the epidemic, people who acquired HIV when they were sexually active in their 20s and 30s at the beginning of the pandemic are now in their 50s and 60s. And so there's this huge bolus of people. But those people, fortunately, aren't seeing, huge increases yet in their comorbidities. We're seeing them, but in terms of statistically significant numbers, it's not happening. And it stands to reason that you would start seeing those in older populations, that they're going to happen, but we don't have enough of them to do that. So it's a huge gap, and one that's not being addressed despite community advocacy. The focus within the longstanding cohorts like MAX and WISE is to increase diversity, which of course is really important, but they're also bringing in younger people, which is important as well. But, we're ignoring a really huge, important research question. And as I said at the beginning, this is all going to come crashing down on us if, things start happening to people and we don't have data, we don't have the cohorts in which to study them and the intervention trials to address the issues that are going to be happening to them. So this is really a plea to anyone who's involved in the research to advocate for including older people. Because, as I always say, you can't study aging without studying the aged. The newly minted seniors in their 50s and 60s aren't going to tell us much, but those who are older will, and we need to get them into our research cohorts. So speaking of cohorts, we do have a number that have been formed within the ACTG over the years. And HALO is the big one. It's an acronym for HIV infection, aging, and immune function long-term observation study. And my hat's off to people who come up with these clever acronyms. I can never do it. And this is we have the Reprieve study, which keeps getting rebooted. That's, of course, the study looking at statins in, I think people over 35 or 45. I can't remember the cutoff for that, but it's over 5,000 people, close to 6,000, I think. So it's a huge cohort of older and aging people that could tell us a lot. And hopefully, once they reach the original study endpoint, they won't, as has so often happened in ACTG history with big cohorts over the years, is they have this great group of well-characterized people, a population you could study, and then once they reach the original research conclusion, they don't find ways to keep the cohort alive, and they have to keep reinventing them when problems start happening. So here's hoping for a more proactive approach going forward, where we can retain these people in some kind of cohort, even if minimally followed, so that we have access to them when we need it. And I mentioned the multi-center AIDS cohort and WISE studies, which kind of had a shotgun marriage a few years back when they threatened to cut their funding. And as I mentioned, the NHLBI stepped up and took the lead on that because we're looking at those comorbidities in there. And so fortunately, those cohorts are ongoing, albeit with limited funding, so they can't do as much as they like. But at least these cohorts are still together and functioning, and finally had the men and women together after 30 some years, which kind of begs the question why that happened in the beginning. And then, outside the ACTG, there are a number of large cohorts that we could use, especially taking advantage of their electronic record systems, since we don't have a kind of coordinated one nationwide, despite the language within the ACA. Anyone who's worked with medical records knows that they don't talk with the different systems don't talk with each other, and it's really hard to get data across the systems. But the VA is one of the largest, and they've been able to do a good bit of research, as has Kaiser. There's the SCOPE study up in San Francisco, which is smaller but very intense, led by Steve Deeks and Peter Hunt, doing great work. Victor Valcour had the Hawaiian Aging with HIV cohort, which I haven't heard much about lately, so I'm not sure what's going on with them, but it's one of the early ones that looked at aging. And again, kind of like us here in Palm Springs, Hawaii was a magnet for people with HIV who were retiring, so it made sense to do that. So they were one of the early leaders in that field. And I mentioned Reprieve, and more recently Anchor, the anal cancer prevention study out of the AIDS Malignancy Consortium, also has a similar older population, and is another resource. And it's going to continue, even though, as you probably heard, they reached their original endpoint of determining that screening and treatment did reduce anal cancer rates. So they unblinded the study, and everybody is now on open label. So they've stopped the observation arm, and everybody's on open label treatment and screening and treatment. But that's another cohort of over 5,000 people that could be useful. So how do we move the needle on all this? Well, we obviously need input from all the stakeholders. So obviously people living with HIV and their clinicians, but also service providers, people on the front lines who are seeing the change in needs in people, and recognizing that the current funding structure does not address those. And we need researchers from other networks and cohorts. We were talking about the different NIH institutes, and we need that expertise looking at specifically aging, neurocognitive stuff in particular. We've done a good job in HIV of following that, but I think all these comorbidities that we're seeing need to have experts, and they don't have to be HIV, to be able to inform the research agenda that we create for that. And I've mentioned the various NIH institutes. We have a National Institute of Aging, which it's been hard to get them to focus on this. Their focus right now is heavily on Alzheimer's, and luckily we're not seeing increased rates of Alzheimer's per se and people living with HIV, even though we're seeing more cognitive impairment. So it's hard to get them interested in this. There's the National Institute of Drug Abuse, and this is a huge problem in our communities. We see it a lot here in Palm Springs, but as people get older and they move, they lose their social networks. And especially if they're trying to remain sexually active, crystal is a big factor in the drug abuse that people see, and people go downhill really quickly. One of the biggest complaints of our providers here is, they can address people's, clinical issues. Their HIV is, pretty straightforward to treat, as are the aging comorbidities. But if somebody's having psychosocial issues and decides to self-medicate with drugs, they go downhill quickly, and it's really hard to reach those people. A lot of them have decided, now's my chance to party and play. I missed that in the 80s and 90s. Then they had to have a career and they retire, and it's like, okay, I want to do this, and they do, and it's a huge problem, and driving a lot of STIs as well. We're a perennial hotspot for syphilis. Monkeypox is a huge problem here, and we're not getting the vaccines we need. So STIs or drug abuse are a big issue. Obviously, cancer rates increase as people get older. I mentioned the Anchor study, but we need to be looking at cancer incidence and how to whether we should be screening sooner and treating more aggressively in terms of screening the cancers that we see, because that's one of the biggest killers of people now with HIV. And obviously, mental health, as I've alluded to earlier, is a huge problem. There's a lot of psychosocial issues that come with having lived through the pandemic. PTSD is rampant. There's a term, AIDS survivor syndrome, that has been coined to address the issues of people specifically living with HIV. And there's social groups like Let's Kick Ass, which stands for AIDS survivor syndrome, to help people address that. But all the economic relocation that I've talked about has really kind of upended people. They lost huge numbers of lovers, friends. Their whole social networks were decimated in the earlier days of the pandemic before the cocktail. And once again, now that they're in their 60s, they're being forced out of where they lived. Communities like the Castro and West Hollywood and so forth, and even Hillcrest to some degree, have been kind of gutted, for economic reasons, right? People get priced out and they can't afford to live in their cities anymore and end up in places like Palm Springs or elsewhere, and have to recreate their social networks. And as people get older, their resiliency declines. They don't always have the psychosocial resources they need to do that, and they become very isolated. Again, as I mentioned, can turn to drug abuse. So it's a lot of psychosocial issues we need to be addressing. So we're trying to, as a community, address this through advocacy, as we have throughout the course of the epidemic. And the National Minority AIDS Council and the Federal AIDS Policy Partnership are working with us to get that message to the federal officials and the various agencies that serve and fund services we need, and especially as part of the ending the AIDS epidemic. There's huge amounts of money, but ending the epidemic monies not always a natural to think about aging. A lot of the focus has been on younger folks, but you have to treat people with HIV in order to keep them undetectable, and anything that threatens that obviously is an issue. So we're continually trying to get a place at that table and make sure that older people are part of that conversation. So when it comes to clinical care, what we really need is a geriatric model. And I have parents who are 92 and 94 and failing health, and trying to get them a geriatrician has been impossible. There just aren't enough for the baby boomers, let alone for the HIV population. So we're going to have to get creative in terms of how we provide, geriatric centered care for this aging population. But it really is the best model for dealing with all the comorbidities and polypharmacy. All too often, people, their HIV doctor has controlled their HIV, and they get sent off to specialists with competing prescription habits and so forth. And it doesn't serve people well. They really need a more holistic, comprehensive model of care, and especially if they're dealing with cognitive issues as they get older, or depression, and aren't able to advocate for themselves as effectively as they had earlier in the epidemic. And there's kind of this feeling that people with HIV are incredibly resilient. They've been through so much, they can handle whatever's thrown at them. And I think we're ignoring the fact that's not going to be the case as people get older. And we need to just stop expecting people to always pull themselves up by their bootstraps and advocate for what they need, because it's not going to happen. And when it doesn't, it's not pretty. So, typically over the course of the pandemic, HIV clinicians have expanded their repertoire, so to speak, and provided the care that patients need. And this may be the case here. Whether or not that's feasible and how people in clinics get reimbursed and so forth is another question. But there's a lot that needs to be done, and hopefully it won't all fall on the shoulders of beleaguered HIV clinicians. But there are some movements to create geriatric clinics that are more comprehensive, kind of one-stop shopping. And here's a list of them in various places, in Boston, the UK, Christine Erlandson, who many of us know, in Denver has one at the University of Colorado. Montreal has a good one, headed by Julian Falutz, and in New York, thanks in large part to the advocacy of Jules Levin, who many of you may know is a very vocal advocate and tireless and never takes no for an answer. But it makes him an effective advocate, and he's actually gotten the state to fund geriatric model clinics in the New York area, and Eugenia Sigler has been a leader in that as well. And then, of course, here in California, Meredith Green's Golden Compass Clinic at Ward 86 at UCSF is a model. And there was recently some funding last year approved, I think $5 million to create 5 model research sites or clinic sites rather, across the state to test this out and hopefully to demonstrate that it does result in better outcomes. And we can expand that model, within, the existing networks and incorporate it into the Ryan White clinics, into the FQHCs as well. So I'll stop there. Many thanks to the people listed on the slide. A lot of them at UCSD, like Miley Karras, who's done a lot of really great work on that. I haven't talked about her. Well, let me take a minute. Let me escape from this and stop sharing. Look at the time because we're only at half an hour, and I could talk a little bit about that because we're both working on similar project a number of years back at the HIV and aging workshop that Scott Latender is one of the co-chairs for. We talked about the virtual village concept, which is older people kind of getting together and finding ways that they can support each other in aging in place. And I think the original one started with rich old ladies in Beacon Hill in Boston. And they all kind of pooled their money and hired an administrator to kind of serve as an Angie's List coordinator to help find them services they needed. People would offer to, give rides to each other, to go to appointments. Accountants would help with financial issues and things like that. And then they would have vetted contractors to help, with home repairs and things like that people needed, again, to help them age in place if they were physically able to do so. And so this has expanded across the country in a lot of the retirement communities. And we thought about doing this virtually. And especially once COVID happened, it really made a lot of sense, not only to provide those services and support, but just to help combat the isolation that people were feeling. And as I mentioned earlier, social isolation is a huge problem as people are forced to relocate, lose their networks, and lose their resiliency and their ability to just kind of walk into a room and strike up a conversation with total strangers. Once again, there's a lot of social anxiety, in the population and as a whole, and certainly in people as they get older because of all the various things they've experienced and the PTSD that they may have. So Miley got a grant from Gilead to do that in conjunction with the center, and we have gotten some funding from Merck. And I'm working with partners at UC Riverside, USC, and University of South Florida in Tampa to create a kind of 3-city advisory board to look at, very intentionally look at all the issues, with a number of, classic socio-behavioral research, doing a number of focus groups and structured interviews with stakeholders, obviously people living longer with HIV, service providers, or researchers to see, what people would want in a virtual village, and to use some marketing research techniques to help further refine what people wanted in a model. And then we created a pilot based on that and just finished that a couple of weeks ago, and we'll now be evaluating that as we get to the end of our 2-year funding for this project. And the hope is that we'll be able to get additional funding and continue this going forward. but we think it could be a viable model in lots of places and lots of communities. We very intentionally tested it in 3 communities. Palm Springs is not very diverse, as you may know if you've ever been here. But of course, LA certainly is, and Tampa is as well. So it kind of gave us a broader overview of how this would work in different communities. And we could see this being really useful in more marginalized communities, where people really have the need to form, safe spaces where they can talk about their HIV. Places like the rural South and the African American community. Women often feel incredibly marginalized because in this country, the vast majority of people with HIV are men and gay men. So, it's a completely different experience for them, and they have a much greater sense of isolation and stigma from their communities. Spanish language could be very useful, having different channels, and these are set up on online platforms where there's a lot of flexibility. We used a free one called Discord that was created for gamers initially, but it has all these cool features. And if you can, for an old fogey like me, we had to have our young graduate students kind of walk us through this and do the training sessions to get us up and running. But once you do, it's amazing what you can do and create channels. People talk about their pets and have gardening channels and travel and things like that. So, we're hoping that this would be a great way for people to create community, not only in a hyper-local sense, like the original villages, but also across the country and even the world when we branch out into different languages. I'm working on creating one in ASL because they have chat features. So people in ASL could, quote unquote, talk to each other through video chat and create a sense of community that they don't have because they're very isolated and marginalized, as you can imagine. I mean, everything they do has to be interpreted by a stranger, all their contacts with healthcare and social services. So providing that, we're hoping would be incredibly useful. So that's, one more thing on our wish list for what we do with this, if and when we get funding. So that was a little self-indulgent to talk about our own project, but I thought that was might be of some interest to folks, especially since Miley is doing it there in San Diego as well in conjunction with the center. I know COVID kind of threw a wrench into a lot of that, but it's still ongoing. So I will stop there, and we've got about 20 minutes or so for questions and discussion. I really want to hear what you guys think and what's going on and where you are and what you'd like to see. So I'll check the chat and see if there are any questions.